Hello ladies and gentlemen, and welcome to the second part of the video on hyperkalemia. Last time when we left off, we were measuring our patient's GFR. Now if the GFR is low, you can say that the hyperkalemia may be due to renal failure, right? But if the GFR is normal, what do you do next? If it's normal, you calculate something called the transtubular potassium gradient, or TTKG. Now TTKG is a pretty interesting topic that deserves a video in and of itself. So right now we're just going to look at the practical application of TTKG. Now TTKG is calculated via the following formula, where you are examining both the urine concentration of potassium divided by the plasma concentration of potassium, then dividing that whole number by the urine osmolality divided by the plasma osmolality. Now why that is, again, as I said, is deserves a talk in and of itself. So we're going to look at the practical application of this. Now if the TTKG is less than 5, then it's pointing in the direction of hypoaldosteronism, right? So if your TTKG is less than 5, you can the hyperkalemia is likely caused by either reduced aldosterone secretion, or aldosterone is not able to act because of drugs like ACE inhibitors, ARBs, or heparin, etc. being on board. If the TTKG is greater than 7, then you know that you have normal aldosterone secretion and that the aldosterone is able to act upon the kidney. If the TTKG is between 5 and 7, then you have a suspicion of hypoaldosteronism. So you're not confirmed, you have a suspicion. Now these numbers may vary a little depending on what textbook you read, but these cutoffs I got from UpToDate, so I'm trusting them for now. Now, a lot of you may be wondering, what is the role of aldosterone in potassium homeostasis? Well, it's actually a little bit complicated, but I'm going to give you the simpler version here. You have renal secretion, which causes angiotensin II formation, which then the angiotensin II causes aldosterone secretion. Now you can see I wrote magic here, mainly because you have renin causing angiotensinogen activation, to angiotensin I and then angiotensin II. But we can skip that for now, because all we want to know is that renin causes aldosterone secretion. Now aldosterone goes to the cortical collecting tubules, and there it causes increased reabsorption of sodium from the filtrate or from the urine, and causes increased secretion of potassium into the urine. So that's really key, in that aldosterone is actually playing a major role in potassium homeostasis. After you have done this, we move on to the EKG, where we can see interesting changes. Now it should be noted that EKG changes do not correspond to the degree of cardiotoxicity, okay, and that the EKG changes can occur at very different potassium levels. So it's not that an EKG change will only happen at a specific potassium concentration, they can happen at different potassium concentration. The order of the changes is usually, and again the keyword being here usually, is along these lines. You have peaked T waves, you have loss of P waves, then you have a prolongation of the QRS complex, you have prolongation of your PR interval, you have sine wave pattern developing, and you know this is a bad sign when your patient has a sine wave on an EKG. And then you have asystole or VFib, both being bad conditions. Okay, now again, just want to remind these EKG changes can occur at any potassium concentration, and by that I mean usually above the 5.0 cutoff. Also, there are also different kinds of AV blocks that may also result from hyperkalemia, such as second degree or third degree AV blocks. Now to the exciting part of this talk, the treatment. Alright, so one thing that you need to know is that if the patient presents with renal failure, presents to the emerge in a really bad condition, right? Like if the patient is near death, you know they have a history of renal failure, they have EKG changes suggestive of hyperkalemia, you do not wait for the blood work to come back. You treat them on speculation. Remember that. That's really key. Now, when a person comes in and you suspect that they may have hyperkalemia, your first step, of course, is to do an EKG, right? Then you do stat electrolytes and renal function, and you also move on to your second step, which is then initiating treatment. Now, as I said before, you have two options here. You initiate immediate treatment, and this is usually done if the patient is, for example, symptomatic, has EKG changes, and as I mentioned before, history of renal failure or any other condition that may put them at risk for hyperkalemia. The other option is that you tailor your treatment options to potassium levels, and this is if the patient is stable. Okay. Now, how to do this? If the potassium level is greater than 7.0 and or they have EKG changes, you use treatment options 1, 2, and 3, and we'll get to what these treatment options are later. And again, this particular category usually falls in the immediate treatment category. If the potassium is between 6.5 and 7, then you use treatment options 1 and 2. And if the potassium is less than 6.5, then you use treatment option 1. And of course, it's again up to clinical discretion. If the potassium is less than 6.5, some clinicians may choose to go with more treatment options. Again, it really varies. Okay. Now, what are these treatment options? Well, they are as follows. The treatment option number 1 being removing potassium from the body. Of course, a couple of ways of doing this. You can remove it from the urine using things like furosemide, or if you suspect hypoaldosteronism, you can use fludrocortisone. Okay, which acts kind of like aldosterone. The other option is to excrete from the stool or gut. Okay, so here you give K-exalate, also known as sodium polystyrene sulfonate, and it's a cation exchange resin. You usually use K-exalate with sorbitol, so that not only should you get the potassium into the poop, you need to get the poop out of the person. The second thing is you can also use a K-exalate enema. K-exalate enema. And the next thing, you can get it out of their blood directly using hemodialysis. It's usually life-threatening hyperkalemia that you resort to hemodialysis. Now, 4 major ways of driving, your treatment option number 2 is drive potassium into the cells. And 4 ways of doing that. You can use insulin. Usually use this with a D50W amp, so you don't cause hypoglycemia, because then you're just making your patient worse. You can use a beta-2 agonist such as salbutamol nebs, and both insulin and the beta-2 agonist work by stimulating sodium-potassium ATPase. You can also use sodium bicarbonate. Usually this is reserved for patients who are acidotic. And some people also suggest giving a bolus of fluid. And what that does is that if they're hypovolemic, it corrects for the hypovolemia and bumping up their GFR. So if they have CHF and they have hyperkalemia secondary to CHF, giving fluids in and of itself might help resolve some of the hyperkalemia. Your number 3 option is protecting the heart. A couple of ways of doing this. You can use calcium gluconate or calcium chloride. Calcium gluconate can usually be given in the peripheral veins. Calcium chloride needs to be given via a central line because it's really irritating to the veins. Okay, and this basically protects it by decreasing the deactivation of sodium channels that happens after hyperkalemia is there for a little while. So as we had talked about before, hyperkalemia initially decreases the threshold for muscular excitation, but as it progresses, it causes an inactivation of the sodium channels, which then causes a lot of the symptoms of hyperkalemia, both cardiac and muscular. And the calcium gluconate protects against this inactivation of sodium channels. So that's how it's useful. And of course, for prevention of potassium, a couple of things: put your patient on a low potassium diet, avoid drugs like ARBs, ACE inhibitors, non-selective beta blockers, and heparin. And of course, minimize episodes of fasting, because if your patient is fasting, guess what? They have less insulin release, and that puts them at increased risk of hyperkalemia. If you have any suggestions for improvement, give me a shout at bharatbehal@gmail.com. Always looking forward to hearing thanks. You like the stuff or you didn't like it. I'm just glad to hear back from you guys. All right. Thanks for listening and have a good one.